Hey, this meeting is being recorded. The recording will be posted on the commission's webpage shortly after the meeting, and TVW may also be streaming this meeting live and archiving it for additional viewing opportunities. And for everyone's reference, today's agenda can be found under the first tab in the materials. And now Vicki Lowe, Chair of the Universal Healthcare Commission, will call the meeting to order.
Thank you, Mary. Welcome, commissioners. It is now 2:04, and I call the August 15th meeting of the Universal Healthcare Commission to order, and we will begin by doing a land acknowledgement, and I will give that. I would like to begin by acknowledging that as we gather today, we are all on the ancestral homes of Indigenous people. I have the privilege that not all Indigenous people have. I live on the lands of my ancestors, the S'Klallam people, who have lived here on these lands from time immemorial. Indigenous people, despite being removed from their lands where they lived, hunted, gathered, practiced ceremony, and cared for their community members, Indigenous people and tribes, whether officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to address healthcare in Washington State, it is imperative that we address the inequities of the past by understanding their impact on the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you reside. Thank you. All right. Before we go over the agenda, I just want to note a new face and a grateful farewell. So Mary Franson led us off, and she has joined the Healthcare Authority team that supports the Universal Healthcare Commission. So she's been working behind the scenes with Mandy and HMA to get this meeting together. And so we welcome Mary and happy to have her working with us. And then due to some personal circumstances, Estelle Williams is resigning from the Universal Healthcare Commission. We're deeply grateful for Estelle's contributions and the time that she has worked with us. So if you want to open your agenda and go to tab 1, we'll just do a brief overview of the agenda. Next slide. Oh, we're already on the agenda. So we'll start with roll call, and we like to use this opportunity to allow the commission members to get to know each other. We usually ask a question. So this month, the question is, if you could be friends with a fictional character, who would it be and why? Then after roll call, we'll approve the June meeting summary. And then please note that some of our standing agenda items have been moved around and are happening later than they usually do. We had to move some of these items to accommodate the schedules of our presenters, who some are from the East Coast and who are generously offering their time today. The first presenter will be Becky Carroll from the Washington State Healthcare Authority, who almost had to be moved, but she's in an airport somewhere ready to give a presentation. And Becky will provide information and insight from the recent experience of the Apple Health expansion that we've heard about. And then our next presenter will talk about prior authorization. She is Michelle Long of the Kaiser Family Foundation. She'll describe a recent federal rule about prior authorization and avenues for state action. Prior authorization is often suggested as an area of focus for administrative simplification, or what we hear called admin simp. Following Michelle's presentation, representatives from the Washington Office of the Insurance Commissioner will describe ongoing work in Washington with times for questions and answers. Then following those presentations, Gary Cohen from HMA will lead the commission in a discussion about prior authorization. And then following a short break, we will have our public comments. After public comments, Liz Arjun from HMA will lead the commission in further discussion and potential votes. The topic will be prior authorization and the continued expansion for Apple Health. And then we'll hear the Finance Technical Advisory Committee updates from Pam McEwen, who is their liaison to the commission. And then we'll wrap up the meeting with state agency report outs. So now I'm going to turn it back over to Mary to go through roll call.
Thank you, Vicki. Call in members by the first name in the order that's listed on the agenda. The agenda is alphabetical by first name. And so when I call on you, please unmute your microphone and let us know that you're here. And our icebreaker question today, our get to know you question is, if you could be friends with a fictional character, who would it be and why? So I will start by calling Chair Vicki.
All right, I am here. And in most native legends, there's a character known as the trickster, and it's usually a raven. And they are very curious and get into a lot of trouble. So I think that would be my fictional character that I would want to be friends with.
Senator Ann. Senator Ann. Vidisha. Vidisha. Charles. Charles did let us know that he may not be able to make it today. Dave. Dave. Senator Emily Jane. Senator Emily Jane. Joan.
Hi, all.
Yeah.
I am, let's see, present, and I think because I just watched Acolyte, I'm gonna go with Yoda as my fictional character. I feel like that dude has been around, seen a lot. I think I would benefit from some knowledge there. So, Mary, congrats on the new role. Good to see everybody.
Thank you. And I realize it was Senator Emily and the next name is Jane, but we are aware that Jane was not able to make it today. Representative Joe.
Yes, I am here. My fictional character, I'd like to get to know Huckleberry Finn. I think he's very mischievous, and I think that he would be fun to be around.
Thank you. Representative Marcus.
Hello, everybody. I am present. My kids watch a show called Wild Kratts, so either of those characters, they were very like just exploring and having fun and learning about stuff. So I think I'd be either Chris or Martin Kratt.
Mohammed.
Thank you very much, Mary. We just returned from a family trip to Europe, so I'm still jet lagged and I have a little bit of cold, so I may not stay through for the whole thing. But there is a mythical character in our culture called Dagder that we used to be told when I was a child growing up back home. It's a woman that has a lot of powers, but most importantly, the one that she heals everyone of anything, including emotional health. But that would be my my mythical character for this meeting and for the Universal Healthcare Commission. So I'm gonna thank you very much.
Omar. Omar. He also let us know he might not be able to be here. And Stella. Stella. Okay, thank you all very much. I'm going to turn this back to Chair Vicki, who will facilitate the meeting summary.
Thank you. Thank you, everybody. That was actually fun. Please join me in turning to the second tab in the commission book. The recording of the last meeting is posted on our website there. Is there any discussion about this meeting summary or any proposed changes?
None for me, Vicky.
Okay. And then,
Can you see
any,
the-
sorry,
Representative Marcus's hand is up. I don't know if you can see it.
I see it now.
I don't know if this is the appropriate time, and I should have reached out prior, but I know there was discussion last meeting about public comment, so I did want to make sure that in the upcoming House work session that I'm holding, we are going to put significant time. So I'm sorry, I didn't see if we were going to bring that up anyway. So if I'm bringing it up now, I guess. Not super relevant, I guess, to whether or not we captured everything, but as far as discussion goes, I know that was a point that was brought up. So I thought it was a nice way to maybe address what we're all doing and give folks some additional options for public comment through the legislative branch.
Thank you. So I propose that we accept the meeting minutes. So no changes, right? Then, Rip, okay. Without changes then, the meeting minutes without changes.
I second that.
Thank you. All those in favor say aye.
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 Any opposed? Say no. All right, motion approved. Thank you. And then so next, as I mentioned, we have Becky Carroll from the Washington State Healthcare Authority. Becky is the Deputy Director of Medicaid Programs Division at Healthcare Authority and is going to update us on the Apple Health extension. Becky, thank you for joining us. I know you're traveling.
Thank you, Chairman. Appreciate that. Always great to see you as well in this group. Appreciate the time this afternoon. I'm going to just do a quick check here. Hopefully you guys can hear me okay. All right, good deal. Then everything is a go. So really appreciate the time to talk about Apple Health expansion and give you an update on how our implementation went. If we want to advance to the next slide. A little bit of background here. I think the Commission is probably aware, but Apple Health expansion is the latest investment by our legislature to provide coverage to individuals who are not qualified for federally subsidized coverage because of their immigration status. So it joins sort of a list of programs here, as you can see, medical care services, emergency medical or AEM, Apple Health for pregnant individuals, after pregnancy coverage, and Apple Health for kids. We want to advance. Perfect. So back in 2022, we started to lay the groundwork for Apple Health expansion. The legislative branch directed us, of course, to start thinking about what it would look like, what we would need to operationalize a program like Apple Health expansion. We went back with a request, and in 2023, the legislature provided a limited pool of funding and directed us to implement on July 1st of 2024. While the program is not funded at a level that can support all folks who might be eligible, we recognize that, and we have been managing to that. And I would say working with community where we can, and in partnership with our sibling agencies and state entities like Health Benefit Exchange and the Department of Social and Health Services. I will note in 2024, we were given additional funding for the program, so we were able to add additional spots into the program prior to launch on July 1st. If you want to go to the next slide. So for those of you who aren't aware, program eligibility for this is really individuals who are Washington residents, age 19 years or older, have countable income under 138% of the federal poverty level, and do not qualify for other Apple Health programs based on their immigration status. These individuals are also not pregnant or did not have a pregnancy in the last 12 months and are not eligible for federal advanced premium tax credits through the individual market or federally funded medical assistance program. Go to the next slide. So implementation. Like I noted earlier, we worked in conjunction with DSHS and Health Benefit Exchange to implement the program, and internally here really worked hard to ensure that we created a program that mirrored our Apple Health Medicaid integrated managed care program to the extent possible. Obviously, one of our major goals was to provide coverage to as many people as possible, and wherever possible, take advantage of any federal match that might be available to the agency. So one good example of that is AEM, or emergency medical. That is part of the Medicaid program. It is federally matchable. And so we did set up the program so that we could take advantage of those dollars. You can go ahead to the next screen. So short timeline for implementation, right? Really, Healthcare Authority wanted to mirror our integrated managed care program. It made sense that we would want to include the 5 managed care organizations that serve that population. But before we usually start a new contract, we often do a procurement or do a readiness review assessment. Given the timeline, we weren't able to do a procurement, so we did instead a 2-part readiness review assessment. The first part was really looking at performance in the integrated managed care environment. And then the second part was a readiness review based on the contract that we created for Apple Health expansion. In the end, we have moved forward with 4 of our managed care organizations: Coordinated Care of Washington, Community Health Plan of Washington, Molina Healthcare, and United Healthcare. So lots of work went into estimating the service cost of the program. There is some data that exists about these individuals and their potential utilization of services across the state, but nothing as comprehensive as we are looking to provide in Apple Health expansion. And so some of this is based on what we see and experience in the other 5 programs that I noted, and some of this is what our actuaries worked hard to estimate based on other state experiences and based on the information we did have. So we actuarially developed managed care rates into 3 different age bands: 19 to 34, 35 to 64, and 65 to 99. There are some services that are outside of the managed care contract, so those are covered fee for service, like non-emergency medical transportation and high-cost pharmaceuticals. So lots of things go into rates, as you probably know, not just age bands, but the number of enrollees we might have in each age band, how many individuals will come in and out of eligibility. So if someone were to move out of the state of Washington, they would no longer be eligible for Apple Health expansion. So sort of that assumed program churn. In addition, as we looked at that $72 million that was allocated for Apple Health expansion, knowing that there were lots of unknowns, right? Recognizing that piece and the high cost pharmaceuticals that are carved out of managed care, we did set aside 3% or $2.16 million as a reserve to cover any unexpected costs. In the end, the program has around $70 million per fiscal year to expend on service delivery in its current budget. So go live. On June 20th, the state began accepting applications for the program. And again, this was a multi-agency effort. We worked closely with Health Benefit Exchange and DSHS. All 3 agencies were up and ready to go at 8 a.m. on the 20th when we started bringing in applications. Call centers were ready to take calls from potential enrollees. So we really did this as kind of a one Washington framework, and it worked really well. We knew that enrollment would fill quickly, especially for 19 to 64-year-olds. But we were sort of happy, right, that we could keep that open for nearly 48 hours. So on June 21st, we closed enrollment for 19 to 64-year-olds. It was later in the afternoon. And then on July 3rd, we closed enrollment for that 65 plus population, or our classic population. In total, and I'm just going to note this right now, these numbers are as of July 3rd. So they are a little they are a little old, but I think probably that it takes some time to do some cleanup after an enrollment like this. So we do expect to have updated numbers soon. So when I'm talking about these numbers today, just sort of know that we're looking at that reference point of July 3rd. So as of that date, we had 11,936 folks enrolled. We had 300 cases that were waiting verification. So these are individuals who needed to come back in and give us some address information or income information. And left some spots available for individuals that were aging out of Apple Health for Kids or whose after pregnancy coverage were ending either in June and July. And those individuals had through the end of July to respond to their renewal notice and then be enrolled into Apple Health Expansion. In the end, I think we're very proud that we're able to provide coverage to nearly all counties, 34 out of the 39. And to give you a taste of what the diversity is across this population, we received language access requests in 35 different languages. So we did have some transitional folks. There were individuals who were already receiving care through AEM, which is a limited scope benefit. There were individuals enrolled in a qualified health plan over at Health Benefit Exchange that were also eligible for Apple Health Expansion. And then those after pregnancy care and Apple Health for Kids individuals. And then we also had some extended foster care kids. And so really we need, in coordination with community, a very early decision to ensure that those folks were transitioned over into Apple Health Expansion as smoothly as possible. And so this gives you sort of a breakdown of those numbers. We had about 172 individuals as of July 3rd who submitted their renewal for after pregnancy care and Apple Health for Kids. So I do expect that number will go up. We have 691 individuals transition from emergency medical care. 879 come over from qualified health plans over at Health Benefit Exchange, and then 20 individuals from extended foster care. And moving to the next slide here, this gives a great breakdown of enrollment by age. And so you can kind of see how this all evened out here. Again, this is the data through July 3rd, but as a reference there, you can see we had most individuals between the ages of 34 and 54. And then we have a great breakdown enrollment by region. Next slide. And this is sort of a heat map that provides an kind of overlay of percentage of individuals who enrolled in Apple Health Expansion against the number of individuals who are in that particular county. So of course, we did expect that we would have a high percentage of individuals from King County, but we did have great turnout also in Yakima and Snohomish County, as you can see here. And then of course, the 5 counties that we weren't able to enroll anyone from a resident from that county in: Columbia, Garfield, Lincoln, Pomeroy, and Wahkiakum are important counties for sure, but lower population. And this, is great information for us as we move forward and doing continual outreach about this program. So keeping that in mind as we move forward. Next slide. So just wanting to note, this data is always really interesting to take a look at. A couple of things as we move through these next few slides. These are responses that were given directly by the enrollee. So clients by race, the Hispanic origin responses here, and then the language preferences. You can kind of see what we got for a language preference breakdown. The the dash over to the right of a language just notes that we did receive a request, but it's less than 10. So with agency policy, we suppress those numbers. So you'll see the ... So there were some individuals who needed Pacho or Samoan, but they were less than 10. As we move forward, I noted a little bit about churn into and out of the program, and we are continuing to look at the numbers, our enrollment numbers, and doing our financial modeling. We plan on doing that once a month. There may be potential here that we can enroll additional individuals into the program. We have developed sort of this interim enrollment management policy that you see in front of you right now. In summary, it basically takes anyone who has come in and engaged the system either over at Health Plan Finder or over at DSHS, and received a denial for Apple Health expansion because of the cap. So they're all sort of put into a pool, and then if we were to have spots available, we can select, randomly select from that pool. So if we've got right around 5,000 as of August 6th who've received denials, and we have 50 openings, then we would pull 50 random names and enroll them into Apple Health expansion. This is an enrollment management policy that we developed quickly with our Community Engagement Advisory Committee. And we, with a promise to sort of go back out and provide a longer feedback period for community at large. And we are right in the middle of this. And so we have started to engage our Community Engagement Advisory Committee again, other community-based organizations that we've worked with, and community members, trusted partners, and have started a feedback process. So we've sent that out via GovDelivery and through email to folks, really looking to, over the next month, receive feedback about this policy and potential changes to it as we move forward. We want to move to the next slide. That Community Engagement Advisory Committee has been really central to the effort. So this is a collaborative committee. Healthcare Authority, HPE, and DSHS all co-lead this particular committee. It includes advocates, community-based organizations, and we have a couple of folks with lived experience. They've been able to provide us some feedback and input into different areas of implementation, specifically for Apple Health expansion. I just covered that enrollment management policy, but they did give feedback about the managed care contract, about interpreter services, our emergency roles, and readiness review, the second phase of readiness review for Apple Health expansion. Next slide. So next steps, we are looking to make our Community Engagement Committee permanent. Right now, it will still continue to be a collaboration between the three state entities here. And we look to facilitate that permanent committee to really help support Apple Health expansion and the 1332 waiver qualified health plans as we move forward. We do want to broaden membership into the Apple Health expansion or into the Community Engagement Advisory Committee to include enrollees into the program, really wanting to ensure that we're meeting folks where they're at. So that means not only talking to community-based organizations and advocates, really, that means hearing from individuals who are experiencing those services. So working hard at doing that. We will continue to provide opportunities for input and feedback and provide transparency into the program to this committee. And I think 4 major areas for Apple Health expansion, right? Outreach, the enrollment management policy, enrollment data, and then policy changes as they come forward. Next steps for Apple Health expansion. Again, I covered about the enrollment management policy. I'll note we have a legislative report due on November 1st. This report will include lessons learned, implementation, the data that we have available for us at that time. I don't know that we're going to have a lot of data around our expenditures, but of course that will appear as we're able to provide that. And then availability of any other federal program or rule changes that might expand access for the population we look to serve in Apple Health expansion. There have been some recent changes to the Deferred Action for Childhood Arrivals, or DACA, which will change some things for Apple Health expansion. And so we'll be working really closely with Health Benefit Exchange in the coming months to develop that policy. We also have a decision package, and that requests funding to provide coverage to more enrollees with enrollment growth sort of phasing in over the next biennium. So with that, lots of information, but available for questions from the commission.
Thank you so much, Becky. It is so great to see like that program from, planning to people having coverage. Just want to remind commissioners, this is one of those things that we supported. So you guys did an excellent job. I was so surprised when the enrollment filled up so quickly, but it shouldn't have been, but thank you. Does anybody have any questions for Becky? Oh, Badisha, hello.
Hi, sorry, I joined a little late.
It's okay.
It's my question was just, do you know how many people were denied? They're kind of waitlisted.
Sure. That's a great question. As of about the 6th of August, it was right around 5,000 individuals who had come into the system, either over at Health Benefit Exchange or at the DSHS, applied, would have been eligible for Apple Health expansion, but were denied enrollment because of the limitations there.
Okay, thank you.
I see Joan has her hand up.
Hi, Becky. Thanks. First of all, thank you for all the work. I have seen the lift you and others in community have made. So I have a question and a comment. My comment is I think it's amazing for a year one program when you look at the qualified health and it sort of speaks to the broader need that if you make these coverages available, people, especially if you make them available at an affordable price point, people, even if they might have some mistrust of the government or otherwise be scared to come forward, are willing to get their health care. So I think the estimates in the state of Washington are that there are 100,000 uninsured, undocumented people just under that. And, when you look all in at who came in and submitted an application through Health Plan Finder, it was over 30,000 people. So to get anywhere near that type of number year one sort of speaks to both the demand and the impact of the initiative. So did want to say that. Looking forward, I know HCA has some outreach dollars. I know the exchange has some outreach dollars we've been using to help support. Do you have ideas, hopes, dreams for how you all, as we think about year two, are going to move ahead and reach some of the, assuming that if there were some more spots to become available and given that we still want to spread the reach, anything new and different you all are thinking about?
Yeah, I think, Joan, this next year will really be about the changes to DACA. We'll need to have some really solid outreach around that. And I look forward to working with you and the rest of the Health Benefit Exchange team to really make sure that we do the best job we can with that. I think our enrollment management policy and the continuing work around that will also be something that we'll do a lot of outreach to community about. We do want to encourage folks so that they can be a part of that enrollment management policy to come back in and apply and get the denial. And I think really wanting to explain what that means. It's very odd to say, please come in so that we can deny you. But if that's really what we end up stabilizing in partnership with community over the next year, I think that's really sort of the messaging that we're going to need to really craft and work really closely, I think, with community leaders across the state. So again, I think those are two big pieces. And then as we move into that second year, once we have some data about utilization and really seeing how enrollees are engaging, I really would like to partner with managed care organizations and with community-based organizations and really talk about the value of healthcare, what services are available to enrollees. Just to touch on Joan's comment earlier, we know there were so many people who were hoping to get in, then there were others that didn't. I got a call from a community member who had talked to early on in the effort. And when I answered my cell phone, all I heard was, I'm in, and then tears. And I at first was like, what is this? What is going on? You've got the wrong number. And then I realized, oh my gosh, it's July, it's June 21st. He got in right before we had to call it closed. And I remembered this gentleman. I remembered his story. I also know that I've heard from him a couple other times because he's like, wait, I have dental. Well, what does that mean? Should I go now? Should I go later? And it's always an interesting conversation. I know our managed care organizations are going to do a lot of work to outreach to these individuals, but I think, again, this is about really understanding the community that we're serving. So continued engagement with them, I think, is going to be paramount to the success.
Thanks so much.
Thank you. Any other questions? Oh, we got like a tight schedule for the next presenter. So thank you, Becky. I really appreciate it, especially knowing you're in the airport. Couldn't tell.
Oh, great. And I really do appreciate the time and the energy and support from this commission. So thank you all.
Thank
Have a
you.
wonderful day.
You too.
Bye-bye.
Safe travels.
Thank you.
Thank you. Before we go to our next presenter, I just want to go to Gary Cohen from HMA, and he's going to give a little history on how we got to here with prior authorization, and then we'll move to Michelle. Gary?
Hey, thank you, Vicki. I'll move through this pretty quickly. I think we're at tab 5, the beginning of tab 5. No, I'm sorry, tab 7. My mistake. Yeah. No, is that not the one either? I'm lost. Hold on a minute.
I think it's 5.
It is 5. Oh, I was right the first time. I apologize. Okay, so we're just gonna real quickly go through the progress of the work plan update. So next slide, please. This is just we've seen this before. This shows the 2 work streams, one working towards designing the universal healthcare system with the unified financing system, and the second recommending interim solutions. And in 2023, the commission determined to be looking at administrative simplification and maximizing coverage in existing programs, and those are the topics today. Next slide, please. And this just shows the flow of the work that we're doing on universal system design. So for administrative simplification, we're talking about Apple Health Care today, and then along in maximizing coverage. And then for administrative simplification, next slide, please. One of the topics is we've covered the general topic of administrative simplification and some of the efforts in Washington State through One Healthport and others. And then in June, we heard from providers. And as part of that, today we're focusing on prior authorization as part of administrative simplification and leading to making recommendations on this topic. And that's it. That's the introduction. So I think we should go to Michelle.
All right. Thank you, Gary. Sorry, my dog is barking. And thank you again to Michelle Long, Senior Health Policy Analyst with the Kaiser Family Foundation, who joins us to present prior authorization, the balancing act of cost containment and access to care. Then following Michelle's presentation, Joyce Brake of the Office of the Insurance Commissioner will provide a brief update about efforts underway in Washington State. Michelle?
All right. Hi, everybody. I'm going to go ahead and share my own slides. I just want to make sure that everyone first can hear me and can see my slides, or just let me know if you can't. Great. Well, thank you for the introduction, Vicki, and thank you to the whole commission for inviting me here to speak today. I'm Michelle Long. I'm a senior policy analyst on KFF's program and on patient and consumer protections, a relatively newer team here at KFF. Although I've been here for a better part of a decade. My policy expertise is in private health insurance, as well as in women's health policy. And just as an aside, back in 2022, the Washington Healthcare Authority was very helpful to us in a study that we were doing looking at access to over-the-counter oral contraception, in particular, some folks at Apple Health, as well as the OIC. So still grateful for that help with that project. My other connection to Washington State is that I used to live there for a short time, a long time ago, and some of my family was there for a very long time, mostly in Pierce County. So good to get reconnected with folks from Washington. Before I worked at KFF, I was a consultant for a couple of Medicaid managed care consulting firms, and then in various roles at the University of Missouri, including as an adjunct instructor for the School of Public Health. And before we dive in, just a little background on KFF. We used to be known as the Kaiser Family Foundation, recently had a big identity change, where now we're just KFF. We are a nonprofit, nonpartisan health policy organization focusing on all areas of healthcare and health policy. We're not affiliated with Kaiser Permanente, part of the reason for the name change, or any health insurer or trade group. And as Vicki mentioned, today I'll be sharing information on prior authorization generally, what the states are doing, and possible considerations for Washington State as it thinks about next steps for prior authorization reforms. And I should also note before we get started that KFF doesn't take any policy positions or make any policy recommendations. So we're just going to go over some basic overviews. So with that, here's today's presentation agenda. I'll provide an introduction to prior authorization. Then we'll touch on recent federal laws and regulations. We'll dive into some of the different state initiatives and reforms. And then we'll wrap up with some policy options and considerations for Washington State. And I'll leave a few minutes for questions at the end, though I do have a hard stop at 6:20, which is 3:20 your time. I'm in Washington, D.C. So let's get going. So prior authorization, I'm going to refer to it here mostly as prior auth, is a utilization management tool where health plans require providers to seek the insurer's approval before their patient receives a covered healthcare service or an item or drug. Prior auth is also sometimes referred to as pre-authorization, so you may see it spelled out that way. Typically, healthcare providers, physicians, or their staff are the ones who submit prior authorization requests to health plans on the behalf of their patient. And prior auth is actually just one type of utilization management strategy that health plans use. Another common one or related to prior authorization is step therapy. You may have heard, been starting to hear more about step therapy in recent years. This means a patient has to try another, usually lower cost drug before they can step up to a similar, but usually more expensive drug. All different types of payers and plans use prior auth, including commercial health plans from employers, state employee health benefit plans, Medicare Advantage, Medicaid, and they do so in an effort to promote safe, evidence-based, and cost-efficient care. Prior auth is typically applied not to every benefit that a health plan offers, but is usually is strategically decided to apply to certain higher cost services and items, such as durable medical equipment. Think about wheelchairs, for example, genetic testing, which is becoming more and more commonplace, GLP-1s, obesity, and diabetes drugs, which have been in the news plenty, so I'm sure you know a lot about, are very costly. Diagnostic imaging, such as MRIs, as well as inpatient hospital stays. Sometimes with prior auth, you can see that it can sometimes intentionally or unintentionally also lead to substituting one healthcare service or one drug or item for a different one, for better or worse. And some examples here are a plan requiring physical therapy, maybe a certain number of times before or instead of having a back surgery, for example, or requiring a patient to use a lower cost equivalent drug instead of a higher cost specialty drug where that is medically indicated. So you've probably heard a lot about prior auth denials and problems that patients and providers have been having in recent years. Discussion of those problems have really ramped up. Some of the more common reasons that plans will deny a prior authorization request is some of them have found that the request is for something that's not medically necessary based on whatever the criteria is that a plan uses to determine medical necessity, which we'll get into a little bit later. oftentimes, very common, plans will say that providers are not submitting the required documentation. Sometimes plans or providers submit incorrect billing codes. As you know, there are many, many thousands of billing codes out there. And then occasionally plans will receive a duplicate claim. So a provider will submit a claim for something more than one time, oftentimes accidentally, of course. So perspectives on prior authorization, whether it's good, whether it's bad, reasons for using it, kind of some of the drawbacks really vary, depend on who you're talking to, of course. So, and specifically, they differ between health plans, between physicians and patients, although providers and patients oftentimes cite some of the similar perspectives. So for health plans, from their perspective, prior authorization can help prevent enrollees from receiving medically unnecessary or inappropriate or low value services and drugs. They'll sometimes point to, for example, requirements around opioids and other potentially addictive medications, and steering patients and providers away from those to safer alternatives. Those are just a couple of examples. Oftentimes they'll say that that a test or a diagnostic image really wasn't necessary. And then from the provider perspective, you hear a lot about the burden that prior authorization places on providers. They require additional staff sometimes to be able to go through the entire prior auth process, which can take weeks, if not longer in some occasions, as well as just hours spent working on paperwork and kind of the administrative bureaucracy of some prior authorization requirements. From a patient's perspective, oftentimes, we know from some research that we have actually done, there's other research out there too, that shows that sometimes having prior authorization requirements can lead to patients getting delayed care that they need, which can sometimes exacerbate health conditions, or foregoing the care that they needed or that their doctor recommended entirely. So how commonly is prior authorization used by health plans? I'll start by noting first that prior authorization practices vary by payer, by state, even by the type of service or the drug. And there has been an increasing interest in prior auth in recent years, as I mentioned, both among payers as a cost-cutting measure and among providers and patient advocacy groups, of course, looking to reduce its use or structure it differently to ease some of the burden on providers and patients. Although there is some federal reporting laws around how often prior auth is used by health plans, specifically private plans, those requirements have been pretty slow to catch on. There isn't a lot of complete data out there at the national level looking at the frequency of prior auth requirements. So there are the goals there of certainly increasing that amount of data, better understanding what plans are requiring prior auth and when. But those have largely been unrealized at this point. However, KFF was able to conduct an analysis of CMS marketplace transparency and coverage data. So this is the area where there actually is some information is in marketplace plans, specifically in those that are using the federal platform. So what we found was that 8% of the 45 million in-network claim denials in healthcare.gov plans were for lack of prior authorization or referral back in 2021. Though I should note that there is some data missing, and of course, we don't have uniform data across states that are using state-based marketplaces. Turning to Medicare Advantage, we have a little bit more comprehensive data, or more comprehensive data is available to the public There's more reporting requirements for Medicare and managed care plans on the use of prior authorization. My colleagues on the Medicare team here at KFF also did an analysis on prior auth and Medicare Advantage. They found that virtually all MA enrollees were in a plan that required prior authorization for at least some services or drugs in 2022. Over 2 million of the 35 million prior auth requests submitted to MA in 2021 were either fully or partially denied. Only 11% of those denials were appealed, but when they were appealed, they had a success rate of 82%. Excuse me, getting over a cold. So what this shows, and this isn't that different from the private insurance market. Appealing denials is pretty rare, but when they are appealed, they tend to be successful. There's also slightly more data available for Medicaid managed care organizations for at least some services. And a 2023 report from HHS's Office of the Inspector General found that Medicaid MCOs denied about 1 in 8 prior authorization requests, and most states actually have very limited oversight of prior auth denial. For state employee health benefit plans, we're touching a little bit on lots of different markets here. A 2021 survey of state employee health plan administrators identified excessive or inappropriate utilization as a primary cost containment initiative, with more than half of states implementing prior auth in the past 3 years for their employee benefit plans. So as I mentioned at the beginning, we're gonna go quickly through this though. I apologize. Opinions of prior auth vary depending on your perspective. So we'll start here with the insurer perspective. So America's Health Insurance Plans, also called AHIP, is the country's largest trade association for health insurance plans. In 2022, they conducted a study of their members to find out what they thought about the use of prior authorization in their plans. So this is just kind of a smattering of some of the report findings, which they put together in an infographic. Some of the highlights are that in general, of course, plans tend to be more supportive of prior authorization practices than providers or patients. They put a large focus on the provision of higher value care and more cost efficiency of that care. They cite outside data that low value care costs the US healthcare system over $300 billion a year. They believe that prior authorization practices can help lower that. They also cite unnecessary diagnostic imaging as a contributor to higher costs, including for patients, which you can see down in that left corner there. So the survey part of this report found that over 8 in 10 commercial insurance enrollees were in plans where less than 10% of drugs were subject to prior authorization. And similarly, they found that about 9 in 10 enrollees in commercial plans were in a plan where about a quarter of healthcare services are subject to prior auth. So this is down in the bottom right-hand corner. So these findings seem to suggest that most services and drugs from the health plan's perspective do not require prior authorization. They also found that many of their members rely on evidence-based sources in designing their prior auth programs. This has been a big point of contention among opponents of prior authorization requirements in terms of what are they using to decide whether they're going to approve or deny a prior auth request. The health plan study here shows that the vast majority of actually use evidence-based or peer-reviewed studies in making their decisions. When prior auth requests are denied, the AHIP survey found that the most common reason is because the provider did not submit the necessary clinical information. And then again, AHIP is actually generally supportive of efforts to automate prior authorization procedures. 7 in 10 members report that lack of provider use of electronic health records, which is a component of automating this whole process, is a barrier for plans to actually implementing automated services. Now for provider perspectives, so the American Medical Association, the AMA, also conducted a study in 2023 of its member healthcare physicians or providers on their experiences with prior authorization practices. So what you can see here, that again, they had a similar kind of infographic type of report. As you can see from the findings, providers tend to have a more negative view of the use of prior auth, especially when it comes to the burden on providers, as well as physician burnout, which we've heard a lot about lately, especially since the pandemic. For example, providers reported spending an average of 12 hours per week working on prior auth requests. More than a third of them have staff who are specifically designated just to work on prior authorization. That's there up in the top right-hand side. About a quarter of physicians said that prior auth requests are often or almost always denied by the health plan. Again, it's typically the providers who submit these requests to the health plans directly. The majority also said that they have seen an increase in the number of denials in the past 5 years. Providers as well as patients can appeal prior authorization denials. That is a legal right. However, fewer than 1 in 5 physicians say they always appeal adverse decisions, with most saying that they don't appeal them because they don't think that they're going to be successful. It's not worth their time. So leads us to the question, what, if anything, do payers and providers actually agree upon? So in 2018, seeking to find a common ground on some aspects of prior auth, the AMA, AHIP, the American Hospital Association, and some other groups you can see listed here published an industry consensus statement outlining their shared commitment to pursue strategies to improve the prior auth process. They identified some specific opportunities where they can improve, such as selective application, program review and volume adjustment, transparency and communication, continuity of patient care, and automation to improve transparency and efficiency. We'll dive into a little more details of that later on. The chart down at the bottom actually comes from the AMA, which reports on some of the gaps and barriers that providers experience implementing these strategies. For example, most said that prior authorization requirements can sometimes destabilize a patient whose condition was previously stabilized, but because of the administrative hassles sometimes of prior authorization, that patient eventually their health condition became destabilized, sometimes due to long wait times. Barriers to automation include that physicians actually usually use the phone for completing PAs. A lot of times they also use fax machines still. I'm not sure many other groups who still use the fax machine these days. Some report that their EHR system actually doesn't even offer electronic prior auth for prescription drugs in particular. So let's transition to patients' experiences with prior auth next. The next few slides and data points come from a nationally representative sample that we here at KFF conducted in 2023. Our survey found that overall about 16% of insured adults had experienced a prior authorization problem in the past year. The findings presented here highlight some of the consequences consumers who experience prior auth problems reported experiencing in the past year. As you can see from that highlighted column in the middle, the light blue boxes, consumers who experienced prior authorization problems were more likely to have a negative health consequence than those who did not experience prior authorization problems. For example, 4 in 10 said they had to pay more for the treatment or services than they expected to have to pay because of these prior auth problems. And about a third said they were unable to receive medical care that was recommended by their healthcare provider. Other consequences included delayed treatment and decline in patient health. And the extent to which consumers experience these problems really varies by demographics, by population type. So for example, this chart shows that adults with Medicaid coverage were actually more likely than those with other types of coverage to say that their insurance had denied or delayed a prior authorization approval in the past year. That's about 2 in 10. People who use more healthcare are also more likely to experience problems with prior auth. For example, 3 in 10 insured adults who had more than 10 doctor's visits in the past year reported problems with getting prior auth approval, compared to just 1 in 10 who had fewer than 3 healthcare visits during that past year. Finally, approximately 1/4 of those who sought treatment for mental health conditions or for diabetes also experienced prior auth problems. Obviously, that can lead to possible exacerbation of health conditions or foregoing needed healthcare entirely. And our last finding here from our survey found a general lack of understanding about health insurance, including consumer rights to appeal unfavorable decisions, which could include prior auth or other types of decisions that health plans make about covered benefits. What we found is that 4 in 10 insured adults knew that they have a legal right to appeal an adverse decision to either a government agency or to an independent medical expert. Plans will have their own internal review boards, but there is also a legal right to appeal a decision outside of that an external agency. 6 in 10 either weren't sure whether they had this right or they just responded incorrectly that they don't have that right. Again, variation here by plan type or coverage type. Those with Medicare were more likely than those with employer-sponsored insurance or ESI, marketplace coverage, or Medicaid to know that they have the right to appeal. Only 1/3 of those with ESI or marketplace coverage knew that they have this right. And interestingly, it's not shown here, but we actually didn't find a lot of differences by educational attainment. So I think the findings here suggest that the importance of these efforts that the federal government and that a lot of states are taking to try and improve health insurance literacy. So we've talked about payer, provider, and patient perspectives and experiences with prior auth. Let's wrap up this section with system-wide impacts. In short, prior auth policies, the impacts on prior auth policies on cost, quality, and access are still somewhat open questions. There's been a limited number of studies that have been conducted, and generally they've found either mixed or limited impacts on health systems as a whole and the use of covered benefits by enrollees. Some of the impact studies have found include cost savings that could be realized for specific items or services. For example, there was a study on powered wheelchairs and requiring prior authorization for those, finding that it did cut costs without necessarily compromising patient access. Some studies have also found that prior auth can lead to a shift of potentially harmful services or drugs to those that are less harmful. I mentioned this at the beginning for medication-assisted opioid treatments, removal of prior auth for those treatments can lead to a decrease in opioid use. Some studies have found, the extent to which prior auth has reduced healthcare spending overall, though, really just isn't clear at this point. And some studies have found that it could actually increase total costs for certain patients. Let's move on to some federal laws and regulations around prior authorization. I realize I'm running out of time here. So we'll touch briefly on recent federal regs for Medicare Advantage, since some of these rules actually predate the newest federal rule that applies to many other types of plans. As a quick overview, more than half of Medicare enrollees are enrolled in Medicare Advantage, which are managed care contracts that are administered by private health insurers that contract with the federal government. Here are some of the highlights that the new federal rules in the past couple of years specify for Medicare Advantage plans. I'm going to go ahead and just kind of breeze over this one. And then I want to talk more here about the newest federal regulation on prior authorization that was issued in January, I believe, of this year. This applies to a much broader swath of the market, although there is actually some overlap with some of the provisions of the federal regulation for Medicare Advantage. So this new rule is known as the Advancing Interoperability and Improving Prior Auth Processes. And what it does is it aims to streamline prior auth processes and improve transparency. Those are kind of the large overarching goals. It'll apply largely uniform prior auth standards across all insurance programs that CMS oversees. So that's the Affordable Care Act, marketplaces that are run by the federal government, which is more than half of the state marketplaces, Medicaid and CHIP, both fee-for-service and managed care, as well as Medicare Advantage. So what does it do? So it helps implement policies and requirements related to electronic data sharing and APIs. I'll admit I am not a technophile, and so I'm still kind of learning about APIs. But what that stands for is application programming interfaces. It sounds very complicated, but think of applications as apps like you have on your phone. If you have an iPhone, the health app that can connect with, say, your Fitbit or other exercise tracker or sleep monitors and that sort of thing. So these are just apps. APIs are part of healthcare software, and they allow information systems to communicate and exchange data between them, to coordinate care, to share patient information securely, and to connect databases. There's a lot of examples out there of APIs being used in healthcare. A couple of them include Epic and Allscripts, electronic health records. Mayo Clinic has a symptom checker API for providers. And of course, Google and Amazon provide data management and analytic APIs as well. These can be used by both providers and payers. Patients with this new regulation will also be able to have access to their information through patient access APIs. Again, the highlight of this rule is increasing the use of electronic processes to share data needed for prior auth, to improve the speed of prior auth requests and the efficiency. It'll also help allow providers and payers and consumers to know what medical items and services require prior auth, what documentation is required for the plan to make a prior auth decision, and the current status of a prior auth decision. Payer APIs have to make available the prior authorization status again, date of approval or denial, the circumstances under which prior authorization would end, what medical services or items were approved, reason for the denial if it was denied, and the administrative and clinical information that was submitted to the plan by the provider. Another central feature of this new rule is transparency. There's been lots of efforts in recent years to improve healthcare transparency overall. All payers that are covered by this final rule will have to report aggregated information about prior auth determinations, with the goal being to allow objective evaluation of the efficiency of prior auth practices for each organization. Public reporting information will be available directly to consumers, although we'll touch on what some of the kind of limitations of that might be in order to review a payer's website. However, important to note, CMS will not be aggregating this data and providing it. Before I jump ahead, the new rule also shortens timeframes for prior auth decisions. The next slide will jump into that a little bit more. The new rule is expected, as stated in the final rule, expected to save at least $16 billion over the next 10 years largely by cutting delays in care and reducing provider administrative burden. Electronic streamlining also will help with these cost savings. It is also expected to cost payers nearly $1.6 billion over 10 years. This is largely due to having to implement these new systems. All right. So here are some of the new time frames. I was actually hoping that my little blue boxes were going to pop up here, but they did not. So The new rule sets a federal floor of required timeframes. States in some capacities can actually require tighter timeframes. This applies only to medical care and items. It does not apply to prescription drugs. So the column on the left shows the impacted payer by this rule, and the next set of columns shows the current required timeframes for payers to issue a prior auth decision. That last two set of columns shows the new timeframes. So what I'll highlight here, and that I hoped my slide would highlight, are just what's changing. So for a standard prior authorization request for Medicare Advantage, Medicaid managed care, CHIP managed care, the timeline is now going from 14 calendar days down to 7 calendar days, starting in 2026. And then changes for Medicaid fee-for-service, CHIP fee-for-service, they're going to be going from, for Medicaid, which didn't actually specify in federal regulation what the time frame was for either standard or expedited. Standard will now be 7 days. Expedited services will be 72 hours, same for CHIP. And then for qualified health plans on the federally facilitated exchanged, those actually are not going to be affected by this change. Again, I noted that this begins in January of 2026. The API requirements that we just talked about have been delayed and won't be implemented until 2027. Okay, so let me go back. My slides are a little bit messed up. Apologize. So there's a lot that this does do and a lot that it doesn't. So as I mentioned, the new rule applies specifically to medical services and items. It does not apply to prescription drugs. Some states do have their own rules about prior auth requirements for prescription drugs. It also doesn't include most employer plans and not state-based plans sold through state-based marketplaces. It doesn't specify what the process is for how decisions are made, such as whether they use clinical standards, whether they have peer-to-peer review opportunity. Information on the specific services denied is also not required. So plans will have to report the percentage of prior auth denials, but not actually any real detail on those denials. Furthermore, the use of the APIs is actually voluntary for providers, and it remains to be seen how useful of a tool they're going to be for patients to also kind of understand how prior auth works. As we know, a lot of consumers don't have the time or necessarily the health literacy to be able to understand this stuff. And appeal structures, there will not be any specific guidelines or standards for how appeals to denials are structured. Okay. So in addition to those federal regulations, there's also been a number of either passed or proposed federal laws that touch on prior auth. So for example, we've got the Federal Mental Health Parity and Addiction Act. The Affordable Care Act talks about requires no prior authorization for emergency care. The No Surprises Act, which helps shield patients from certain out-of-network billing or surprise billing, also touches on prior authorization for emergency services. And then we'll wrap up our discussion on federal reforms with a brief mention of some additional laws that have been proposed that would impact specifically to Medicare enrollees. The Improving Seniors Timely Access to Care Act, which, as you may know, was introduced by Representative Del Bene in Washington. I'm going to not dive into every detail here, so we're running out of time, but it has been reintroduced after passing in the House a few years ago. Didn't move anywhere in the Senate. So it would require a lot of the kind of similar details that we talked about. It would prohibit Medicare Advantage plans from utilizing faxes or proprietary payer portals for prior authorization. It permits insurers to create gold carding programs. Those are programs where certain healthcare providers who have had a certain share or rate of prior auth requests approved over the last, say, year may not be subject to prior authorization any longer for a certain period of time. And then they're looking into how to implement real-time decisions on prior auth requests for routinely approved services. These apply to items and services, but not Part D drugs, importantly. So let's talk about some state initiatives, since we've talked about what's going on at the federal level. So nearly all states have passed some sort of law, some sort of reform to prior auth practices, usually related to clinical criteria, transparency, and so forth. More than 90 prior auth reform bills have been introduced already in 2024 across 30 different states. States are continuing to take an interest on this, so you can expect to see the momentum keep going. Some of the common themes, again, already kind of discussed a lot of these. And here's just a map showing all the states that have implemented prior auth laws. There are only 3 actually: Nevada, Wyoming, and South Carolina, that have not implemented any prior auth laws. And then the green box, the green states, are those who have implemented more comprehensive prior auth laws to protect patients and reduce provider burden. Those in the blue have these laws, but are maybe less comprehensive, or there are fewer aspects to them. So Georgetown University Center on Health Insurance Reforms recently conducted a study of just a handful of states' prior authorization laws as of April. Those include Washington State. If you have not read this report yet, I highly recommend it. I did not work on this at all. Arkansas, Illinois, and Texas. So this is a chart that they publish. It shows some of these areas of reform each of these states are employing. Transparency reforms, for example, include requiring the disclosure of prior auth information, such as items and services that are subject to prior authorization, criteria used to make prior authorization determinations, reasons for denials. Standardized request forms require certain elements of information or limitations on the length of the form to help reduce provider burden, and others. So you can see across these 4 states, and Washington's the first one listed here, have implemented the majority of these types of reforms. And I want to talk really quickly about, towards the bottom, disease and service exceptions are getting a lot of attention too, although not without controversy. So what these entail would include things like a mandated approval or limiting the number of prior auths that insurers can require for certain types of health conditions or services. Care continuity protections include requirements on how long prior authorization approvals must last. For example, they must last for at least 90 days before they have to submit another request. Restricting payers from adding additional prior authorization requirements mid-year, and prior notification before a prior auth approval is set to expire. So, as with anything related to health policy in general, there's always trade-offs. Everything has a trade-off. So some studies, including the Georgetown study I just mentioned, have examined these trade-offs for different types of prior auth reforms. In the interest of time, I'll highlight just a few of them. So, for example, those disease and treatment exceptions that I mentioned, an improvement is that they could improve timely access to care, for example, for substance use disorder treatment, for PrEP, which can help prevent transmission of HIV, cancer testing and treatment. All sound like good things. On the other hand, some opponents or some who are critical of this practice say that the selection of specific exceptions could be politically fraught For example, we know that there's a lot going on politically around plans being required to cover PrEP, or they could just be arbitrary. A lot of times these provisions are promoted by drug companies, which then exposes them to additional scrutiny. A couple of other state level initiatives to highlight here. So for example, New York is prohibiting prior auth during the first days of inpatient admission for mental health treatment for children. California plans have to use generally accepted standards of care developed by an outside nonprofit association for relevant clinical specialty. Also, California requires coverage of at least one therapeutically equivalent HIV/AIDS prevention drug, such as PrEP, devices, and products without prior authorization. Tennessee plans are not allowed to require prior auth for substance use treatment. Maine can't require any prior auth for medication-assisted treatment of opioid use disorder for pregnant women. And Oklahoma, this is still pending. Would require plans to disclose use of AI and algorithms in utilization review process. We could talk about AI all day. That's a topic for another discussion. Although I mentioned at the beginning of the presentation that there's really limited information on the overall impacts of prior auth on the health system generally, there have been some smaller scale studies looking at the impacts of specific state laws and regulations on healthcare costs, as well as the utilization of healthcare services. For example, in Vermont, just recently, when submitting their proposed rate increases for 2025, marketplace insurers predicted significant cost increases as a result of increased requirements and limitations on the use of prior auth for 2025 plans. We have a few others here. Massachusetts has a really great study. Massachusetts Health Plan Association, I think it was, did a great study looking at on what the elimination of prior authorization for current services in their commercial and MCO markets could increase premiums by about 5% to 7%, due in large part to increased use of specialty drugs. This study was specific to drugs. And then we have a few others here, which I will leave for you to take a look at. I've included links. Again, in the interest of time, I'm gonna skip by the initiatives that Washington State has been taking. Obviously, as you all know, there have been a ton of reforms. Washington has really been a leader in reforming prior auth practices, as well as in collecting data, which is really important. So I think I will actually let the next speakers from OIC talk a little bit more about Washington State is doing, but just to highlight a couple of impacts on from the data that's now reported in Washington about prior authorization. Couple graphs here. This shows the number of prior authorization requests from 2020 to 2022 for certain service categories. The top DME is durable medical equipment. Not a whole lot of changes there between 2020 and 22. Obviously, your eye probably goes to the bottom there, which is outpatient medical and surgical care. You can see the green bar there on the top there is from 2022. You can see over 400,000 prior auth requests. That's an increase from 196,000 just in 2020. And then plans in Washington that have over 1% market share are also required to report prior auth approval rates by service category. So these are the same service categories you can see over here at the right. So you can see some slight changes over time. For example, prior auth approval rates for diabetes items, for example, have increased slightly from 2020 to 2022. Outpatient mental health substance use treatments have kind of had a downward spike and then back up in 2022 to almost 99% of them being approved. So we're going to wrap up here with a quick exploration of policy considerations, some potential strategies for Washington State as they move forward. As a reminder, neither I nor KFF makes policy recommendations. But in general, the goal with these reforms, I think, is to refine prior auth policies and processes so that they retain their benefits while minimizing the associated burdens to the healthcare system, to providers, and to patients. Reducing the time and cost burden to providers and patients through standardization, process automation, informed targeting of requirements can all increase the net benefit of prior authorization reforms and programs. So pulling from research and lessons learned from other states, a range of policy options could include standardization of services and drugs covered, gold carding. Again, we've talked a little bit about that. Texas actually has implemented a pretty comprehensive gold carding rule, again, for providers who have had a high rate of approval successes. Also adoption of EHRs. Again, go back to a lot of providers are still using the telephone, still using fax machines. It's also worth noting, however, that healthcare providers often are not the decision makers on whether they use EHR or automated systems in general. Most providers now work for a health system. The health systems are the one that makes these decisions. So this is not to say that providers do not want to do these things. So final slide here. So when designing or modifying prior auth laws and regulations, I think it's important to think of some really overarching broad questions related to the feasibility, the potential intended and unintended consequences, and the impacts on all stakeholders. A lot of state laws and reforms have been happening because of advocacy from patient and provider groups. So of course, the impacts on them is very important. Also have to think about the impacts on payers, on health plans, and overall costs. So some basic questions, food for thought as you all move forward, is, do prior authorization policies, do they save money for patients? So when we say that something saves money, you have to ask for who? Who does it save money for? Does it save money for patients, for the payer, for providers? Is there any added value to requiring prior authorization for certain services? And then also considerations of health equity too. As we saw, patients who use a lot of healthcare, who have chronic conditions, are more likely to experience problems with prior authorization. There are also language barriers to consider, which we didn't even dive into here, but language barriers and health literacy barriers for patients to even understand what this whole process is and how to get through it. Use of AI, again, a long topic here. There's been a lot more interest in research in the use of AI, as well as skepticism over how secure and accurate the use of AI can be. And in this context, I'd say the use of AI to either approve or deny prior authorization requests, which has also received a lot of scrutiny, has been in the news, specifically for Medicare Advantage plans. So how will plans be required to use AI, if at all? And will patients and providers be required to be notified if a decision was made based on an automated system? Additionally, nimbleness to adapt to changing technologies and treatments, changing technologies being artificial intelligence, or new treatments such as genetic testing, for example. How are these prior authorization rules and regulations able to adapt to those changes over time? And they will keep coming. Compliance and enforcement is really important, of course, to any law, any regulation. Who is going to be responsible for for enforcing regulations related to prior authorization? What are going to be the mechanisms for that, and for ensuring that plans are compliant with these rules? Finally, important to think of how you're going to measure success. For example, reporting and data needs will have to be considered. Prior auth requests and denials by services, by enrollee characteristics. So there's going to be a huge lift for gathering the data, to help determine if a measure has been successful. These are just a few of them. So I'm going to go ahead and wrap up. I know I've gone a little bit over. I'd like to open it up for just a question or two, and then I have to dive off. We will probably not get through all of your questions. If not, or if you think of additional questions later on, please feel free to email me. Here's my email address on the slide here. So I think I will turn it over to Vicki for a question or two.
Thank you, Michelle. Does anybody have any questions for Michelle? Gary.
Thanks, Michelle. And this was really great. I had two quick questions. One is there data on what the impact of gold carding requirements that states have adopted has been? And then the second one was the big increase in prior authorization requests from 2022 or 2020 to 2022. Is some of that a COVID issue?
Yeah, I'm glad you mentioned that. So to your first question, Texas is a state that comes to mind with requiring some use of gold carding. It is pretty new, so I do not think that there is a whole lot of data out there. I know that some plans have also voluntarily, across the country, have also voluntarily are starting to implement gold carding policies. In part in response to that industry consensus agreement that I briefly talked about. But I think that it still remains to be seen what the impacts are going to be. In terms of the utilization data from Washington State, yes, any healthcare data that you see out there that involves the pandemic period, the height of the pandemic, is take that with a grain of salt. Obviously, there were a ton of changes in how people utilize healthcare during the pandemic, and then kind of the after effects of that with when things started to reopen with patients seeking more healthcare. So absolutely, that's a good question. I'm going to go ahead and sign off here. I want to thank you all so much for your time. Again, please don't hesitate to contact me if you have any questions. And I hope you all have a great weekend.
Thank you, Michelle. Really appreciate it.
See if I can end the slideshow here. There we go. Okay, goodbye.
There you go. All right, bye. And then next we have Joyce Brake from the Office of the Insurance Commissioner to talk about some of those Washington efforts that Michelle mentioned. I think Joyce is calling in. Joyce? Are you there, Joyce?
We're working on unmuting the phone.
Okay. With the tribes, we work a lot on the fee for service, and I noticed there wasn't a lot about that, but I think there's fewer prior authorizations under fee for service is what I remember. I don't know if anybody knows any different.
Vicki, can you hear me?
Yes, we can, Joyce. Thank you. We are
Great.
already.
Apologies, I was having a hard time with the unmute function.
It's okay. Go ahead.
Vicki, is there any particular time frame that you want me to stay within? I know that we were scheduled to, be in discussion at the time. I can make this as short as you need me to.
Well, we had a 25-minute discussion afterwards to be done at 3:55. So whatever you can do, Joyce. I do think it's important to get the information.
Okay, great. Hello, everybody. My name is Joyce Brake. I am the Policy and Rules Manager at the Office of the Insurance Commissioner. I have been very involved in the implementation of House Bill 1357 from session 2023. Representative Schmick was one of the sponsors of that legislation. So you can shift to the next slide. I wanted to, before I kind of dive into our most recent efforts in 2023, I wanted to kind of cover where we started when we took on that prior authorization legislation. There are several prohibitions in place in our statutes already. So carriers cannot require prior authorization for the first 3 days of inpatient substance use disorder treatment or the first 2 days of withdrawal management. Opioid use disorder medications, that there's a prohibition on prior auth for that. Emergency services, including behavioral health crisis services and emergency ground ambulance transports. HIV post-exposure prophylaxis drugs, and then certain cancer biomarker testing. So those are, portions of the statutes that already prohibit prior authorization for those services and drugs. When we took on prior authorization modernization in 2023, you can shift to the next slide. The greater goals were to improve health outcomes by preventing the delays in care and to really pull out that red tape within the process, which adds to provider burnout. So at that time, what was already in law was that carriers had to have a documented prior authorization program description. They had to use evidence-based clinical review criteria within those prior authorization determinations, and they had to respond to prior authorization requests promptly. So the timelines at that time for standard prior authorization requests were 5 calendar days. And for expedited prior authorization requests, it was 2 calendar days. So that's kind of where we started in 2023 with the most recent prior authorization modernization bill. Next slide. So House Bill 1357, just a general overview, it shortened those turnaround times for both standard and expedited prior authorization requests. It applied to both healthcare services and to prescription drugs, and the timelines differed depending on electronic or non-electronic submissions. So some definitions that were written into the law were, further defining of standard and expedited prior authorization requests, and non-electronic and electronic has actually been brought into the rulemaking process, and we've worked in coordination with the HCA in defining those terms. Next slide. So the expedited and non-expedited definitions. The expedited request, that it was further defined in the legislation. It hinges on a situation where the passage of time could either seriously jeopardize the life or the health of a patient or subject a patient to severe pain. So in addition to that, electronic and non-electronic has been defined. The HCA kind of took the lead on those definitions. We brought in a lot of input from interested parties on how to define those terms. And within the HCA's MCO contracts now, those are defined as, electronic is defined as kind of looking into the future on this whole application programming interface. So, electronic is defined as delivered through a two-way communication system that meets the requirement of a secure online prior authorization process. And then non-electronic, which was kind of, surprising to our rule team at least, actually includes email, phone calls, text messages, faxes, and mail. So, as Michelle covered, we're moving towards this interoperable two-way secure communication system within prior authorization requests, and those definitions reflect that change. There was a plain speak emphasis within the new legislation, so it requires carriers to communicate their PA requirements in detailed and easily understandable language. Within that clinical review criteria, the law requires it to accommodate new and emerging information related to the appropriateness of clinical review, applying that clinical review criteria in prior authorization determinations as it relates to people of color, gender, and underserved populations. So our rule team, had some pretty detailed discussions about whether or not that needs to be further defined in rule. And then I believe Michelle mentioned too that 1357 also expanded upon the 2020 prior authorization reporting requirements to also include prescription drugs. Next slide. So this is that process automation that is also required by the legislation. For healthcare services, an API process is required by January 1st, 2026, and for prescription drugs, January 1st, 2027. So if you move to the next slide, we did a comparison of Washington's law and the federal rule. As you can see, the applicability is a bit different. The scope of services, the major difference between Washington's prior auth modernization and the federal rule is that we include prescription drugs in our applicability and the federal rule does not. There's differences in components of the API requirements, and then in terms of enforcement, there are some timeline differences in that ours goes into effect first of the year 2026 for healthcare services, 2027 for prescription drugs, and then the federal rule excludes prescription drugs and goes into effect for medical items and services on January 1st of 2027. So that is, kind of an overview of where we started from in 2023 when we took on prior authorization modernization. I thought it was really interesting to see Michelle's chart, the Georgetown study that kind of laid out where we've been on prior authorization legislation and where we haven't been. So yeah, I think the last slide is just a context slide. Does anybody have any questions?
Gary.
I had one
Joe.
quick one. I went through your the OIC report on prior authorization, and I noticed that there was a wide variation in the number of health plans that were reporting with respect to the different issues that were, or issues that were questions that were asked. And I was wondering if you could explain why that would be, and if there are efforts made to try to get more reporting from the health plans.
That's a great question, Gary. And I have not been involved in that report, but I know that Simon can kind of, outline the trends within that report. So I'll be sure to ask him this question and have him get back with you.
That would be
Thank
great.
you.
Thank you.
Joan?
Yeah, hi, Joey. It's Joan from the Exchange. I was curious if you all had done a look at that. Michelle mentioned the Improving Seniors Timely Access to Care Act, that Del Bene kind of reintroducing that, and I'm not sure what its prospects are, but does that, I'm assuming that goes beyond the current federal rule. So have we done any similar crosswalk to where we are and that new kind of proposed federal rule or law?
I don't think so, not that I know of, but it would be a good exercise to compare.
You mean they didn't call you and ask you what should go in the federal bill when she reintroduced it, or nah, that's on her. Thanks.
It could be a Jane question, but
All right. Thank you, Joyce, and thank you for getting through that so quickly. We still are a little behind. There's supposed to be a break at 4, and we need 25 minutes for discussion with Gary. So the proposal is to break now, think about all the questions you have, and then we'll come back and have a conversation with Gary about what we just heard, and then we can keep moving on. Is that okay? So if it's 3:47, we'll come back at 3:52. Does that work out right? Yes.
Sounds good.
All
Thanks,
right.
Vicki.
Right. Are we back? Well, I, appreciate the presentations by both Joyce and Michelle, and hopefully you guys had time to get what you needed done, but also to think a little bit about what this means for the work we're doing, and then we'll have Gary kind of take us through a conversation about that. Right, Gary? And you're muted.
I'm on mute. Hello, here I am. Thank you, Vicki. So we have a few questions that we wanted to go through to kind of stimulate discussion on this. The first one, what else would you like to know more about in relation to prior authorization? And I think I would amend that to add also, what did you hear in the presentations that intrigued you the most, or interested you the most, or surprised you the most about the way prior authorization currently is functioning and is being regulated in Washington and elsewhere?
That was a long question. So what would you like to know more about, or what? Okay, Mohammed, his mind works quicker.
Thank you, Jeff. Vicky. Quick question, actually. I don't know if this question pertains to what you were asking for, but I, I think every state is unique. Its people is very unique. They have unique needs. I think the design process of the universal healthcare would be a great opportunity to have, design a pre-authorization process that is, that fits the unique needs of Washingtonians. And I have missed the last commission meeting, so I don't know if we had that discussion, but is there any timeline? And that this question might not be to you, Gary, it could be to Mandy or Vicky or anybody else who has the information. When should we start the design process? Or when should we focus on designing a package that is basically good for Washingtonians? It was a bit winded, and I don't know if that's a question or a statement, but go ahead.
Well, I think that's actually a really good question, because I think when we're talking about prior authorization in particular, there are two ways that you all could be thinking about it. One is in terms of what changes or improvements could be made now. As we've been talking, for the last 2 years about transitional policies that might help improve the system today. But then there's the question of what's the role, if any, for prior authorization in the universal system. And I think that as we move forward in our designing of that system, one of the questions that we will be getting to is what role, if any, are health plans going to have? Because right now it's health plans that are doing prior authorization. And as the presenters pointed out, that raises some challenges and difficulties, because they obviously have a financial incentive. If they deny treatments, then they don't have to pay for them. And that's a big issue.
And Gary, that was why I was commenting on the fee-for-service Medicaid program, because there are a lot less prior authorization happening there. And it's hard to say, because the provider networks are so small, what kind of change that makes for people. Batisha.
Yeah, so I think I'm learning the gold carding thing today. I hadn't heard of that before. And from what I understood, it is based on like a historical performance. Some providers get the gold card. So I think I would like to understand that or a little bit more. I am completely for reducing the burden, especially administrative burden on providers. I think we have heard that from providers before. But it's a trade-off that if somebody just is historically getting approvals and there is no check, then can that lead to some unnecessary use of medical care? And then if there if somebody is just starting a new practice, they just start off with a lot of administrative work. So I guess what I'm saying is that I would like to know that a little bit more. And I'll also add that, is it possible to do Gold Card for, like primary care? Like instead of provider, can it be done for the type of care?
I think the answer is yes. And one approach that has been taken both voluntarily by health plans and through regulation is to reduce the number of services that are subject to primary care, which I think is kind of what you're getting at. If certain services, and one of the things that really struck me from Michelle's presentation was that chart that showed that the percentage of approvals is really very high. So it looks as though they're actually, by percentage anyway, maybe the number is still high because there's so many requests are being made, but the percentage of approvals is very high. And so it looks like we have a system that may be pretty inefficient in the sense that we're looking at a lot of procedures to only eliminate a very few. And I think that if we could identify those procedures where the cost savings and the opportunity for requested services that are not medically necessary are higher, and focus our efforts on those as opposed to looking at everything to only eliminate a very small number, that might be one way to be more efficient and also more better for patients. But to answer your question, yes, I think it's possible to do it both by providers' sort of track record, and also it's possible to look at different procedures and decide which ones should be subject. If you're always approving a particular type of service, then the need for prior authorization would seem to be less.
I saw Representative Schmick's hand go up. I don't know if you still had a question.
Yes, I comment. Since we're talking about prior authorization, I thought it was intriguing about the value. Is it a value add to the patient or a value add to the carriers or the insureds? Because there was such a wide discrepancy between those two reports. So I found I'd like to know a little bit more about the value to each of the parties. Thank you.
Thank you. And Gary, I would just add, when we're talking about gold carding, I'm wondering how it could be connected to the primary care certification work that's going on in Washington State, those 3 levels of certification for primary care providers could, ease of authorization, prior authorization be part of that mix, and what kind of impact would that have? Because that would be across insurers, right?
Right. That was one of my sort of question comments was the gold carding approach of looking at the provider level. Does it allow you to cut across all carriers and kind of leave the door open for whether or not there are plans in a future universal system, or if there are and allow it for the plans now? So I'm trying to clarify what I'm saying, but by focusing at the provider level, it kind of makes the carrier piece irrelevant.
And just to respond, Representative Schmick, to your comment, I think it's an important point because, and I think Michelle mentioned this early on in her presentation, there are many studies that show that a significant percentage of medical procedures and services are not necessary and in fact can be harmful to the patient. And we tend to look at prior authorization purely through the lens of, are we saving money? But there is also an aspect to it that is meant to make sure the patients are getting the best care and the right care. And the question then becomes, who should be making that determination? And whether there is a need for some sort of oversight over what healthcare providers are doing, not because they're bad people or they're trying to, make more money by doing more procedures, but just because we know that there's a variation in the quality of service, and some sort of oversight might be appropriate. Are there any other thoughts or comments on the different types of reforms that, in addition to the ones that Washington has already done, that you all are interested in looking into further? Bedisha mentioned about gold carding. Another proposal that was out there was to try to make this process less burdensome for healthcare providers by having standardized forms and being able to, rather than having different processes and procedures for each health plan, to standardize those across plans. Representative Michelle, I see you have your hand up.
Yeah, just some comments on that, because I appreciated the work Rep. Simmons did and Rep. Schmick did, and I was involved in some of those negotiations, what Washington did. One thing that I'm interested in is really just to see, one of the pieces of moving folks to electronic, to see if it's really working out. Because what we heard was that it leaves less ability for partial forms to be done. And so that in itself could be a real benefit. So I just be interesting to know if that's playing out, because it sounds like there was a lot of back and forth loss because there was incomplete information. And what we were told was that when you do it electronically, it basically forces you into different fields and you can't leave stuff. So that's kind of, if that's a real advancement, that would be cool to kind of understand and know. And yeah, and I think the other thing this was just an observation. When I got involved in that discussion, I really thought that prior auth would probably be a problem for a primary provider in Republic, that was maybe nearing retirement. And the data that we were shown is it's really our urban hospitals that still have a lot of people using a lot of fax and things like that. And so I just think that was kind of spin that on its head. And so while we were kind of pushing insurance companies, I think there was a new, provider responsibility that says like, hey, well, if you're going to do electronic, then we'll do all these things. And I had no idea that it was largely more at our bigger city hospital. I just thought there was a bunch of, primary care providers that maybe were in rural areas, and that was a bias that was completely upended for me.
Yeah, I think that's a really good point too, Representative Rochelle, because one of the statistics that I think Michelle cited is the very high percentage of denials that are really initially just based on the lack of information or the incorrect information or incomplete information that's provided. And that is just kind of friction and waste in the system, that to the extent we could eliminate that, some of the delay and the costs would both be addressed. So do you all feel ready to make any sort of recommendations on this issue, or would you like to come back with some more specific ideas about what might be proposed and look at that at a later meeting? I think that's kind of the question that we have to decide today is moving forward. What's your appetite for doing something on this, or do you want to take some more time to think about what recommendations?
I feel like we're really missing Dave and Jane in this conversation today too. I'm sure they would have a lot to say. How do people feel about kind of tabling that till next meeting, or do you want to like make some recommendations and see if we can get Dave and Jane to catch up through email with their comments?
Well, also just a question to put out there too, Vicki. If we decide to not make a recommendation, if the commission decides not to make a recommendation today, what are other areas that you want to know more about? Some of the things that I heard were want to understand more about gold carding, understanding between the nexus or the delta between what's approved and the provider. I think it was, the value add to the patient versus the carriers. The question particularly about gold carding and connected to primary care work. So trying to get a little bit more discrete. The piece about the electronic process. How is that going? Because there may be some advances that have been done there. I think those were the things I captured. So I mean, we had some potential vote language for later after public comment, but it sounds like want to have perspectives of Dave and Jane here and also spend more time. I see Representative Riccelli's hand at that.
Liz, the only other piece I would add is to see if there's any gaps between what's being currently explored at the federal level and what we've done in Washington. We saw the good comparison of the federal rule and the current law, and I think I'm interested in whether at the national level there's anything in the Del Bene bill that's not otherwise addressed in what OIC is currently working on, which I think is something in the Joyce Jane purview as well.
Go ahead, Rep. Riccelli.
Yeah, I just so I got back, I went to Kentucky and was part of a health innovations task force on health and AI. And so I don't necessarily think we need to do anything on it. I just think in this area it's gonna be really important and interesting. I think there's like with anything we're hearing on, there's a lot of potential benefits. Like if AI is like saying this thing is being approved, like, a bunch of times, and then it's like, well, why does prior auth exist in this particular thing? But then what was brought up in the presentation too about like notification and to patients and folks when AI is being used and how it's being used. And this idea too, which I heard back there, was augmented intelligence. It's artificial intelligence, but then when the human is still reviewing and getting involved, that, and how we're navigating. So anyway, I don't think I really have a proposal there or anything like that, but it's consuming. I can tell you it's consuming policymakers in every field, but particularly healthcare across the country. And it's going to be a hot topic for this prior auth stuff too.
Yeah, and the speaker from KFF also mentioned that. So it's something that you would like to hear potentially more about how that could be.
Yeah, I don't think we would be in a place probably to hear about it, make some sort of recommendation. So maybe it's outside this group, but I just think it's worth bringing up. Yes, it's going to be an important factor as this evolves.
It's going to be an important factor, not just in prior authorization, but in practice of medicine generally. I mean, the last time I was at my primary care physician and the computer told her to recommend to prescribe a certain medication for me based on my lab tests. It was just prompting her, and she looked at me, she says, I don't know why I would do that. So it's going to be, I think you, Representative Rochelle, you raise exactly the right point, which is there a human that's going to be involved in that decision making at some point, or is it the algorithm that's going to make the decision, for us? Well, I think we have some things to take back and come back to you with. So unless there are any other thoughts, Chair Lowe, maybe we can move on to public comment.
Thank you. Yes, and thanks for those of you who might be waiting for public comment. I know we're a little behind, but just want to remind everybody that all the commissioners that public comments received since the last meeting can be found under the third tab in commission book. Representative Riccelli, did you want to mention the about the legislative process for?
Yeah, sorry, I don't know what's going on. There we go.
Yeah.
So I just wanted to bring up, and I think I clunkily did it in the wrong portion, probably around the notes, but that we are going to hold a work session, and I'm trying to think. I think it's September 22nd.
September 23rd at
23rd.
10:30.
Yes, and we've invited some report in from the commission, but also an opportunity for some broader public comment. And it obviously is a different track, but I think it's just trying to elevate the work that's going on both by the commission and also have the public give an opportunity to comment here, but also in front of the healthcare committee. So looking forward to that and that participation. Again, want to be really clear that, it's a different track there, but I think it's an important audience as well, outside of, Representative Schmick and myself, kind of a broader audience to say what's going on and then allow the public to provide feedback to different setting.
So it's the full health committee in the House.
Yeah, work session. It will be remote, but there will be opportunity again for folks we're working on it similar to like a committee hearing for people to provide feedback at the end of the hearing.
Thank you. So we're gonna open up the floor for public comments. We have allowed individuals to sign up prior to the meeting, and we'll start with those who have signed up. If you've not signed up but would like to provide public comment, just please raise your hand inside of the Zoom meeting. Mary will call on you after we've heard from the individuals who were signed up. When you are called upon, please state your name, any affiliation, and before speaking, please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You're also welcome to provide comments in writing via email at any time, and that goes to the full commission. To ensure that everyone has a chance to speak, there is a limit of 90 seconds per person, which may be reduced as we get closer to the time limit. I think we're going to go to 4:30. We will be displaying a timer as a reminder of that limit. When the timer stops, please wrap up your comments. We encourage public comment to be focused on the materials and topics being discussed today. We may run out of time. If we do, you are welcome to submit your comments in writing. And then Mary, would you please start with the names of the individuals providing public comment today? Thank you.
Sure, thank you, Vicki. Of the people who signed up, Catherine Lewandowski signed up, but I am not seeing her name in the list right now, and I'm not seeing Walt Washington. She may be having some internet issues. Is she here? She's here. Oh,
that is me.
my
I apologize.
Can you unmute her?
My husband needed to go to the clinic.
Thank
I'm
you.
on my phone.
All right, welcome.
Okay, sorry. And my notes are tucked in my computer in the back of the car, which I pulled over because I don't like to drive and be on a meeting. Anyway, I just wanted to thank the commission members for all the work that you've been doing. I also wanted to say that we're excited to see how supportive you all were regarding just the universal healthcare and trying to pull all of the smaller people in, like Peb and Seb and the small markets and such. So we wanted to thank you for that, and that we really appreciate that. And then I also wanted to let you know, because last month or the last meeting we were on our town hall series, that overwhelmingly, we heard from so many small business owners around the state, how for them, they really, truly would love to be able to provide to provide healthcare to their employees, but it is just completely unaffordable for them. And so they please no, they just can't afford it. So I hope that you will take that in consideration, when you look at a unified financing plan, and and also, I'm sorry, I got interrupted there. So my thoughts are gone. Sorry, my husband had to interfere. So thank you again.
Thank you. The second person who had signed up in advance to speak is John Godfrey.
Good afternoon, everyone. My name is John Godfrey. I'm the program manager for Washington Community Action Network. I also represent the Coalition Healthcare as a Human Right, and I'm also a small business owner in Seattle. And just responding to the last public comment that Catherine talked about, I'm one of those small business owners that can afford to provide health insurance to my staff, but is a significant cost and has gone up just shy of 20%. The last 2 years. And when I talk to other small business owners across the state, a lot of times they look at me kind of funny, like, oh, wow, you can afford to provide health insurance. You must be doing really well. And it really shouldn't be that way. So just had to give a shout out to Catherine's public comments there. I wanted also to address that the fact that standardizing and drastically minimizing prior authorization which is one of the strengths of traditional Medicare, should be an important goal for our state. Because it's a costly barrier for patients that brings inordinate administrative burdens. I'm also a huge fan of the discussion around expanding Apple Health. At the same time, we understand the importance of considering these incremental steps or the building blocks of a universal healthcare system, but after many months of meetings, the commission hasn't yet taken action to, and I quote the legislation that founded this body, create immediate and impactful changes to access and delivery, and has shown limited progress towards the overall design of a universal healthcare system. And to the many people who've worked tirelessly to establish the commission, this is very concerning. The last thing I'll say is just put a point in question is to Chair Lowe and members of the board is when will the design of a universal healthcare system, including unified financing system, overall be on the commission's agenda? Thank you.
Thank you, John. Those were the two people who had signed up. If you'd like to make a public comment, please feel free to raise your hand. Any more comments? I don't see any hands. Okay, Vicki, I will turn it back to you.
All right. I'm not missing a page. Here we go. Now I'm going to turn it over to Liz. Oh, there's the comments we received through email since last meeting. So if you can go to tab 7 in your book, we'll go to Liz to lead us through the next portion of our meeting. We're going to be talking about support, how the commission wants to support expansion of Apple Health. Liz?
Great, thanks, Vicki. We actually, in the meeting packet, there were 2 areas of potential votes or recommendations that we had outlined. The second one being focused on the prior authorization conversation, but I feel like we've decided to hold that for now and eventually come back with more information about particular areas to just really refine what any recommendation might look like. But we did want to have a brief conversation and think about a vote on what we heard about earlier in the meeting from Becky Carroll about the Apple Health expansion. Just to remind everyone, and I know Chair Lowe mentioned this earlier as well, this was supporting the Apple Health expansion was a key piece of the commission's first set of recommendations from a couple of years ago. And it's really great to see that come full circle. But as we all saw, there is already a waiting list for this program. And Healthcare Authority is developing a decision package, as we heard from Becky, to begin to to add more slots next year or over the course of the biennium. And wanted to just open up it to see if there's any questions or discussion about that, and then talk about having if there's an interest in having a recommendation, voting on a recommendation to support that decision package or anything else related to the Apple Health expansion. Because we did not have a chance to discuss after Becky's presentation. So just wanted to see if there were any other questions or pieces that we wanted to talk about with that. Are folks interested in moving to a vote for a recommendation on supporting the Apple Health expansion? Oh, go ahead, Joan.
Thanks, Liz. Yeah, I think I'll say that I think the outstanding need that's been demonstrated in the rollout of the program for the number of people who have interest in the program and were unable to gain coverage was pretty notable. Becky mentioned the 5,000 in the queue, and those are people who just have come back in since essentially knowing that the program has been closed and being told, to try to get on that wait list. And there's tens of thousands of more who came in and just haven't come back to get that denial. So I think we have demonstrated need from the data that's available. So in my view, there's nothing that has happened in the rollout of the Apple Health expansion program that would change, to me, it would only strengthen the prior position of the commission rather than weaken it. So I guess I to the extent that the commission's already acted to support the program, there's nothing I heard in Becky's presentation that I think would change that view or change the need for that view in my mind.
I would add that I support Joan's comments that, just how the rollout happened and how quickly those spaces were filled just shows the need for the program. And I'm happy that we supported it in the first place, and I think we should continue to support it and the continuation of expanding.
Okay. Well, we have some draft language around a motion if we want to just go to the next slide. And again, this is just draft from staff. And if you all would like to revise it or make a motion, the floor is yours.
Would anyone like to make a motion or utilize their own language for a motion? Joan?
Yeah, I think as written, we obviously haven't seen healthcare authorities' decision package or request to move forward, and not speaking to the specifics of that proposal or the specifics of the funding being requested. I think I like the phrasing of continuing to support the expansion, and I'd make the motion that the commission continue its support, and I'd sort of defer to commission members on level of comfort with the recommendation for additional funding, but personally comfortable with that.
So I guess do we hear a second?
I second.
Thank you, Badisha. So the motion is the commission continue its support of the Apple Health expansion program, including recommending additional funding for this program. Are there any other further conversation, questions, comments?
Representative Schmidt, did you unmute briefly?
Could you repeat that, please?
I think she saw you unmute. She just wants to know if you had a comment or question.
I'm in opposition of this. I mean, we can certainly vote, but I'm in opposition to doing this. I have a hard time expanding the program when we are so severely underpaying providers currently. I mean, it's $72 million for this 12,000 that we allowed in, and so that's my comment.
Do you have a friendly amendment maybe, or?
No, not really. Not with the what's being proposed there. That is just my comment.
Okay. Other comments? More discussion?
Chair Lowe, I would note, I don't think we have a quorum.
We don't have a quorum, do we?
No,
All right.
I'm just running the count now, and I don't believe that we currently have a quorum. We may need to table this until the next time.
Okay. We can't even vote to table, so we're just tabling it.
We will just table.
All the plans of world domination at this meeting getting thwarted.
Ruined by a quorum. Okay. Well, thank you. Go ahead, Bidisha.
So actually, based on what Representative Schmick just mentioned, kind of leads me to ask this question. So, you know, the presentation was really good, and I am supportive of expanding or continuing our support for the Apple Health Expansion Program. I guess it would be good to know what the additional funding for the program will bring. So I understand that, you know, a lot of people are waitlisted, and it would be nice to give, you know, to be able to, you know, include as many people as possible, but it's worth also thinking about the providers. Like, is the additional funding going towards the providers too? Like, one problem with Medicaid has always been that it pays providers much less compared to the other insurance. So, you know, we have seen presentations where just because you have Medicaid doesn't mean you have access to the care that you need, because if a provider doesn't accept Medicaid, then where are you? So I think it would be, I mean, I would like to know, where would the additional funding go? Who would it help? Is it just, you know, enrolling more individuals, or can it also help the providers?
Thank you. And I think that's something we can ask to Becky and the folks at HCA, Mandy.
The additional funding goes to pay the premium. Joan, I want you to jump in and correct me if I'm wrong, but the additional funding goes to pay for premium coverage for those programs.
Yeah, my understanding is that a package being contemplated that would increase, Representative Schmick mentioned the 70 million for the current 12,000 spots. And I think the proposal will, in an integrated way, ask for increased funding to essentially increase the number of spots of people who could come off the wait list in successive years. So it would be paying for the coverage for designated number of people year one, increased number of people year two. And to Representative Schmick's point, I don't think it gets to the underlying reimbursement for Medicaid providers. I think there's a separate bill vehicle that's been looking to do that.
All right. Any other thoughts, comments, questions? Okay, well, we're back on schedule, shy 1 minute. Unless, is there another slide, Liz, or we already talked
that's
about
it.
the prior auth? Okay.
That's it. So,
All right. So our next speaker is, sorry, Pam McEwen, who's going to give us an update from the Financial Technical Advisory Committee. Pam, are you there?
Yeah, I'm here. Can everybody hear me?
Yes.
Thank you, Vicki, and thank you everybody for hanging in for my presentation here. I know you've been through a long meeting with a lot of information. FTAC has been busy in the weeds on some elements of a universal package design. If we could go to the next slide. So well, we spent a lot of time at our last meeting talking about consumer cost sharing. And to give you some context, this came up in discussion, I think, at one of your previous meetings, where I think that this group has been really uncomfortable with cost sharing. I think a lot of us are. Cost sharing, the initial idea was to, better manage utilization and to give consumers some skin in the game. But I think currently, studies are showing that people are foregoing needed care because of cost sharing. And I know when I was at the exchange, we had the experience of people, despite everybody's best effort, choosing plans that they couldn't afford because of really high co-payments. There's also been a significant amount of shifting costs to consumers from employer plans. As employers have had to grapple with the high cost, they have tended to opt for plans that have a lot of consumer cost sharing that people may be really unprepared to deal with if their family has a health situation. So in looking at it, trying to design kind of an ideal system, most countries that have a universal system do have some kind of cost sharing. So we tried to look at it, kind of go up 30,000 feet and look at what some of those issues are and what some of those possibilities are. Really good discussion. And I think we'll be coming back, with potentially an idea about options or how you might think about options or principles related to cost sharing. The other thing that we got into was I think it's on the next slide, which is how we would look at the benefit packages that are going to Milliman. And this is also kind of bouncing off initial work that you did. It's how to think about different benefit packages that Milliman would look at it for purposes of comparison, so that we could cost out what the population groups that we've agreed to, what would it cost to provide benefits to those groups. So the plans that we chose were the Cascade Care Silver benefit coverage plus adult dental. And the silver shouldn't be considered a preview of how we're thinking or how we're suggesting that you think about cost sharing. It just is, it is the most basic, clear plan, as close to a benchmark plan as you can get for the exchange. The second was the PEB/SEB benefit coverage plus adult dental. And the third, Apple Health Medicaid Managed Care benefit design plus adult dental. And then this will not be enough for Milliman. They're going to need much more guidance and what are the assumptions. Actuaries care a great deal about assumptions. They don't like to be wrong. And they're going to be asking us for much more how to think about the populations that will be covered. And then what are our assumptions about measures that we might take to mitigate cost increases? So are those going in are we front loading those things, thinking about those things in advance so that lowers the overall cost of care, or do those things come later? So those are things that we have discussed back and forth between the commission and with FTAC, and we'll be diving into those more deeply, I believe, in our next meeting, in addition to what kind of guidance we would want to come back to be more specific with Milliman. So those are, what we are calling step 2, which is modeling different cost sharing options. And then again, looking at some of the cost mitigations that are being considered. I know you must all be exhausted, but are there any questions for me or for FTAC?
Pam, is it okay if I just make a quick comment for folks?
Sure.
Because I know I think it's come up a couple of times, wanting to know. We heard a couple of public comments about when is universal design happening. So just to remind everyone that is really that the commission earlier this year kind of voted or asked for some guidance from FTAC to help with some of these questions. And we've been there, FTAC has come back at different points to ask for some clarity around things like benefit packages, because what's happening right now is earlier this year, with input from the commission, FTAC clarified what kinds of benefit packages we wanted to have Milliman look at, how much it would cost. And then secondarily, Milliman in their questions to FTAC in that conversation have said, we need to know more about cost sharing. So that's why and what you think it should be so that we can cost it out. So this is an update to all of you, telling you, the commission, this is where we're at in that process. So I hope that helps folks understand that this work is happening and it's kind of a back and forth right now, and hoping that later this year we'll have some cost estimates for you to react to based on guidance from FTAC.
Thank you for that. We get into kind of a chicken and egg situation where Milliman just needs more. We want to know kind of broad outlines from Milliman, but Milliman is saying we can't get to those broad outlines unless we have more specificity. So we're going back to develop more specific guidance for them.
Anybody have any questions for Pam or comments? In my mind, I'd really like to see the cost sharing part of the premium and not, point of service, if that's an option.
So Vicky, you're saying to be at the
premium? Yeah, the cost sharing to happen at the premium level
and rather than at the point of service.
Yes.
Yeah. And I think that's
that
really
can be an option. Yeah.
And what looking at some other systems, a lot of times, point of service cost sharing is really minimal, so that would be unlikely to be a barrier, or it's prohibited completely at certain income levels. So that's also another way to think of it. And then, another option is to have no cost sharing at all, but then you have a much more expensive system, and that has to be funded through premiums and taxation. So, there'll be a lot of trade-offs to discuss.
Anyone else have thoughts for the FTAC? I mean, it's a nice range of plans and benefits. All right, you guys, you falling asleep? I had a cup of coffee earlier.
Vicky, I was just going to echo what you'd said about, I like that we're leveraging known benefit designs as a starting place, so that then as we think about potential levers to expand them, that I think it's nice that it spans the exchange and then the various HCA programs. So I think it sort of covers the spread, which is great.
Thanks, Joan.
Representative Riccelli.
Yeah, and this is more of just some commentary and just with what FTAC's doing and how we're positioning ourselves in the state. There was a piece of legislation last year to try and standardize plans on the exchange, which I think as we move forward could really benefit, just some of the, I know what can be frustrating, but some of the important incremental steps. And I would just say, one of the opposition comments is like, well, this is just trying to set up universal healthcare. I would say absolutely. So I'm not sure where we're at on that. I'm looking forward to some discussions in the fall, but I do think a move on the exchange to standardize plans could be a significant policy intervention that could help us with broader momentum. So I just felt like I would say that. I don't know if it fits in.
No, I thank you. I mean, it's good to know about the possibilities with legislation.
Yep, and I would add that the standard plans on the exchange have consistently shown that they have lower cost sharing than non-standardized plan options, so that there's a tie to the cost sharing work there as well.
Thank you. All right, anything else from anyone? Pam, did you need something from us out of this? You were just kind of giving us an update.
I think one of the things whether there would be any pushback on, I think that FTAC needs some latitude here to push into some of these discussions about cost sharing, how we how we give guidance to Milliman on these. I think we have really broad support that these are the right three. But then as we kind of dig into how we guide Milliman, I think FTAC needs time to discuss that and dig into that. And I think also in terms of how we think about costs, I think there'll be transparency back and forth between the groups, but we actually, given that we meet our month, we meet on opposite months. I think the most important thing is that we just provide a lot of transparency, and the staff obviously are all good at carrying messages between our two groups, but that's where that would really be the only thing we'd be asking for, unless you have any additional things you want us to be digging into. And I'm not hearing that right now from this meeting today.
Yeah, I think the FTAC is there for their expertise, and if they feel, they need to ask or dig into specific things, that we ought to let you guys. Anybody else? All right, Pam, I just want you to know that I take silence as agreement.
Me too.
Thank you so much. And thank you for the work you're doing. It's really important. And so,
Thank you.
Move forward. All right. So our last agenda item of the day is the state report. Alex and Joan.
Yeah.
I think this is the Joan show.
I'm happy to provide a 30-second state agency update from the Washington Benefit Exchange to close us out. Thanks for the time. Things that I think might be of most interest to committee members. So we launched the qualified health plan expansion earlier this year, and then, in supporting the work of the Apple Health expansion, now have some updated information that we're sort of looking to compile on how many folks were reached. So we did a immigrant health coverage snapshot back in the fall that we're looking to update. So can bring that, circulate that to commission members of interest once it's available this fall. Becky mentioned the DACA implementation, which this is the federal rule that would allow more people to gain coverage through the exchange and access tax credits. It's the subject of some federal litigation, so lots of back and forth, but another incremental step to potentially expand access to more affordable coverage if it moves forward. And that would also be something happening in the fall that we can provide some more information on, but we're working on. With Cascade Care, Representative Riccelli mentioned standard plans and revisiting legislation that would standardize plans or help standardize them in our market. We're also looking really carefully at affordability issues, given federal subsidies may be expiring after calendar year 25, and our state subsidies aren't fully funded after 2025. So more to come there, but certainly to the extent that affordability is a barrier today, would be more of a barrier moving forward without those two really important subsidization streams as we're looking to address affordability in the system writ large. So doing some work there. And then it's on our interim solutions or transitional solutions list. So we are starting to work on a legislatively directed study on automatically enrolling or facilitating people coming off of Medicaid into a qualified health plan. That's a population that churns quite often. We see and we know that people are losing coverage as part of that transition. So we've been asked to look at ways to help connect people to $0 plans on the exchange. So have started that work. And I think we're on the commission's agenda to bring back sort of a deeper dive in that look as we get closer to the fall. The report is due at the end of December. So that's it from the exchange. Continuing to work with our colleagues at OIC. They did put out an affordability study that was recently submitted to the legislature, so it has a lot of good information that will sort of inform some of the affordability work the state is working on. And then I know Dave is also working on looking at further aligning and addressing cost in PEB and SEB and putting together some proposals there. So more to come. I guess I'll also offer a preview of coming attractions from James and Dave as well.
And that we'll be getting a presentation on the OIC affordability report next meeting, right? Liz, Mandy, Mary?
Yes.
Yes. So good. We'll be hearing about that too. So that's great. Thank you, Joan. Any questions for Joan? I'm really interested in what Dave's working on with PEP and SEB. Especially we've got those comments about the expansion and small businesses. Really hope we can figure that out, because I think that will really help bring more people into the same coverage. Okay, I can't believe this, but I think we're going to be done early. All right. Before we close, though, I need to remind everyone that in your meeting packet is the draft report that's due November to the legislature. And so it wasn't an agenda item, but just a reminder, if you could please go through and send in your comments, written comments via email by August 30th. So we have a couple weeks still, day shy of a couple weeks, I think. And just make sure you get your comments in. I don't know if there's any questions about the report. All right. Thank you, everybody. I don't know what was specifically grueling about this meeting, but thanks for your attendance. The recording and the summary will be on the Universal Healthcare Commission web page on the Healthcare Authority's website. Our next meeting will be October 10th at 2 p.m. And just a reminder, it's 2 p.m. to 5 p.m. So pack a lunch. And I look forward to seeing you at that meeting, but many of you will probably see before then. Thank you. Have a great evening.
Thanks, Vicki. Much appreciated.
Bye.